Good morning, students. I'm Dr. Shamla from Department of Orthodontics, and today you're going to learn about open bite and deep bite. Yes. So, in learning outcomes for this class, we'll be learning how to identify or what is the etiology behind the open bite and deep bite, and how do you diagnose and formulate a treatment plan for these conditions. Now, as we all know, in layman's term, what is an open bite? Yes, so basically an bite is something which is, failure to meet. Yes, so it is open, right? So definition is something like this. An open bite is the failure of a tooth or teeth to meet their antagonist in the opposite arch. Yeah, so when there is a lack of fusion between your upper and lower teeth, it's called as open bite. Now this is very important, your MCQ question. Open bite is also called as apertognathia. Yeah, so we can twist the question and ask, maybe what is the failure of tooth of your maxilla and mandibular teeth called as? So an option can be apertognathia, or your MEQ will be how do you manage a patient with apertognathia? Okay, so you must know that we are talking about open bite, right? So open bite is a condition of malocclusion wherein there is no overlap between your maxillary and mandibular dentition. It occurs in a vertical plane, so it is a vertical plane malocclusion, which is also your MCQ question. Now, based on the area of occurrence, it is classified into anterior and posterior. Yes. Okay. Now, when you go into a detailed classification, okay, you can basically classify it on the basis of region, which can be your anterior and posterior, on the basis of your etiological factors, which can be your skeletal or dental open bite, and on the basis of your molar relation, which can be your class 1, class 2, and class 3. Now, there is one important thing which you can clinically evaluate a patient, yes, with an open bite. Okay, so basically a simple open bite, okay, it is occurring only between your incisors. Yes, a complex open bite extends from your premolars or deciduous molars from one side to the other, and a compound or infantile open bite, okay, completely involves, opening from your including your molars. And an iatrogenic open bite basically means a consequence of your orthodontic or surgical therapy. Okay, so the open bite is caused because of your orthodontic or surgical therapy. Now, what is an etiology of open bite? Okay, so basically it is multifactorial. Yes, so it can be because of your habits. The most important cause of your open bite is because it happens of its habits. Okay, so you can have a prolonged thumb sucking, which can be one etiology, prolonged tongue thrusting, okay, nasopharyngeal obstructions or mouth breathing, an increase in tongue size and abnormal growth pattern of your maxilla and mandible. Now, it is important to know, okay, the features of skeletal open bite and how a dental open bite looks like. Now, when I say skeletal open bite, okay, basically you see an increase in your lower facial height. Okay, definitely the face tends to be much more elongated or increased in the total facial height. Okay, so there is a decrease in your upper facial height, increase in the lower facial height. Okay, anterior, increase in the anterior and decrease posterior facial height, steep mandibular plane, small ramus of the mandible and body, long and narrow face, as I said, clockwise rotation of your mandible, extrusion of your molars. How does a dental open bite looks like? So mostly you will see proclination of your upper anteriors, upper and lower anteriors which fail to overlap each other, and a narrow maxillary arch because of the tongue posture. Okay, now how do you diagnose a patient with an open bite? Okay, so clinically Okay, we call something a pseudo open bite when the patient has an overjet and overbite of less than 1 mm, right? A simple open bite is an open bite of 1 mm, right? So when you say an anterior open bite or a posterior open bite with just 1 mm, it is called as a simple open bite. When I say a complex open bite, right, the open bite is extending from your deciduous molars on one side to the other, right? And when I say compound or infantile open bite, it is completely open, including your molars, right? And what is an iatrogenic open bite? It is basically a consequence of your orthodontic or surgical treatment. Okay, now how do you diagnose a patient with an open bite? Cephalometrically, what do you see? Definitely you see, okay, a growth pattern change. Okay, so if it is an either a vertical growth pattern, that means there is a protrusion of your upper anteriors and lingual inclination of your lower anterior incisors, right? In horizontal growth pattern, you may mostly see upper and forward tipping of your maxillary base. Now, how do you manage a patient with an open bite? Okay, so basically there are three stages or three ways on how you can manage. First is orthodontic correction, surgical correction, and combination of both orthodontic and surgical correction. Under orthodontic correction, you must first know the etiology which has caused it. Once you know the etiology, it is easy to treat. Now, suppose a habit is the etiology, okay? So you give a habit breaking appliance, right? And if you see a growth of your maxilla or the mandible is the problem, you give an orthopedic or myofunctional appliance, right? So depending upon what the etiology is, you have to focus or stress more on it. Now, there are a few habit-breaking appliances that can be given, which is your tongue crib, vestibular screen, and bluegrass appliance. So many things, right? Myofunctional appliance, you can give an activator, bionator, Frankel 4, twin block, and Jasper jumper. Now, other ways on how you can treat orthodontically is your elastics. Few most common are your elastic magnets and most importantly implants. Okay, and there are a few more also as you can see. Now, surgical correction basically involves surgery, right? Orthodontic surgery. So usually there are the most common would be your for the maxilla leaf one osteotomy and for your mandible is your bilateral sagittal split osteotomy, right? But there are a few more that you have to know, which is your anterior maxillary and mandibular subapical osteotomy, Cole's modification of subapical osteotomy, sagittal split that I was talking to you about, leaf 1, yes, and genioplasty just for the chin deficiency. Now, going into detail about orthodontic correction, okay, so first thing is habit breaking appliance, right? So, tongue crib. So, basically, when there is an anterior open bite, okay, you make a palatal acrylic plate, okay, horseshoe shape with a labial bow and a crib or a spike. You all have done in your preclinical exercise a tongue spike similar to that. It is like a crib, which is like a gate in the front instead of a spike. So you can either give a tongue spike or a tongue crib, right? And the most important thing is the crib should be placed 3 to 4 mm lingual to your upper anteriors. Right? It should be behind your upper anteriors by 3 to 4 mm. Now, posterior open bite, the crib is placed away 2 to 3 mm away from the teeth. Okay, in some cases, fixed cribs are also used. Now, vestibular screen is basically given for a patient with a mouth breathing habit, right? So it is an acrylic shield extending from your one side of your molar to the other side of the molar. It is like a screen that is covering the entire teeth and your alveolus, right? So the most important problem here is when a patient is a mouth breather, how do they breathe when you have a sheet of acrylic around your mouth, right? So we drill some breathing holes in your acrylic, right, to identify that problem. Right. So this is a kind of orthodontic break brackets, okay, which we don't usually use now. okay, but you just know multi-loop because there are so many loops here, okay, edgewise appliance. Now, elastics is very, very common and it has been using till, which has been used till now, okay, to correct the open bite. It is usually used with stainless steel arch wires. Yes, so let me show you a picture. Okay, so this is your braces. Yes, so this is your elastics, right? So you have your braces, you have an arch wire that goes, and you have your modules, or you have ligated each bracket, right? Now, when you have an open, this is called as hooks, right? So, for, or you can call as a Kobayashi hook, right? Which is basically used to engage the elastics. Now we have a hook attached to your brackets itself, okay? But in some cases, you need to make a hook yourself with your ligature wire, right? Or you can have the soldered hooks available in the market. Okay, so the elastics that we usually give are vertical elastics. Okay, so it goes from, suppose you have an open bite over here, so you give an elastic from this half to this half. Okay, so the upper to the lower. When the patient is opening or closing or doing any function, okay, the pressure of the elastic will try to close, okay, the open bite, right? Here, as you can see in the picture, okay, this is only at this region. When you want the full anterior segment, better to put 4 for the 4 anteriors, right? Now, magnet, as you know, were started to introduce by Ali Darren Dealer from 1995. Okay, he called it as MAD4, which is magnetic activated device for to correct the anterior open bite. As you all know, because of the attractive force of the magnets, okay, the open bite closes. Now, this is not used now, but initially it was very popular, right? Something like this. Okay, so this is the attracting magnet. Okay, so when you try to close, it gets stuck to this one. So the mouth will close. Okay, but what was not very comfortable for the patient and hence it has been not used, as you can see in the picture. Okay, moving on. Implants are very, very common and popular and is used until now, okay, as managing a patient with an open bite. Okay, so initially Beth Prosterman, okay, in the year 1995 was the first person to come up with the idea where implants could be used in the correction of open bite, right? So mostly implants are given in par with your fixed orthodontic appliance, right? He concluded that since osteo-integrated titanium implants show remarkable resilience to pressure, they can prevent extrusion of your posterior teeth, thereby preventing in your facial height. Okay. Now, Leaford 1 osteotomy, okay, this surgery is indicated in open bite cases with high and constricted palatal vault, lip incompetence, high mandibular plane angle, and increased distance between the palatal root apices and the nasal floor. Now, retention and relapse is very, very important. Yes, the main etiological factors responsible for relapse are your growth of the face and the roll of the tongue, right? And the main etiological factors responsible for relapse after the surgical correction involves your mandibular musculature and basically incomplete understanding of your factors influencing the group of muscles. Okay. Um, Retention and relapse. Okay, there is one also important thing that you need to know. Okay, it involves the use of cuspid to cuspid lingual bonded retainers. Okay, yes, with capillin hooks and intraoral elastics if needed, if the case is a worst case scenario, right? Something like this. As you can see, a lingual bonded retainer is placed. Okay. Retention after surgical correction. Now, upper and lower border wiring is very important. As you all would have studied in your surgery class, intermaxillary fixation. Yes, the same logic or concept applies here. You basically tie up the maxillary and mandibular arch together, okay, so that the bone and the muscles and the teeth know their exact position now, okay, so that they don't relapse. Yes, so sustainment used pins to stabilize the maxilla, some wires were used, okay, and some rigid fixation. Now I would like you to see a video here, okay, so that you can understand what happens, right? So this, as you can see, you have the brackets here, the wire there, and this is the Kobayashi hook that I was talking to you about. Yes, so you can see a hook like thing here. So you see this as an open bind. Now I want you all to recollect, okay, what kind of open bite is this, right? Is it a simple one or complex or iatrogenic or what? Okay, so this looks like a simple case of an open bite, right? As you can see, there is a failure of fusion of your upper and lower teeth, and this is now this something is called as the box elastic. It looks like a box. Okay, you stretch like a box. Now there are vertical elastics that can also be given. Okay, but this is mostly what we do, right? So box elastics. Okay, from your, you see the hook here. Okay, stretches to the hook that side and down and to this side. Okay, so that when the patient closes the mouth, the pressure tends to pull the teeth or extrude the teeth, which corrects your open bite, right? I hope you all understood how the elastic works there. Now moving on to your deep bite. Now what is a deep bite? I hope you all know it is also a malocclusion in your vertical plane, okay, where there is too much overlap of your upper to the lower teeth, right? So Graeber has defined deep bite as a condition of excessive overbite, okay, where the vertical measurement between the maxillary and the mandibular margins is excessive, okay, when the mandible is brought into habitual or centric occlusion. Such a condition where there is excessive vertical overlapping of your teeth, mandibular teeth, or with your maxillary teeth is called as a deep bite. Yes. So one of the frequent malocclusion that can occur with other associated malocclusions. Okay, and it is considered as one of the most damaging malocclusion. Now, a deep overbite can be of two types. One is the incomplete overbite, and then you have a complete overbite. Now, incomplete overbite is an incisor relationship in which the lower incisors fail to occlude with either the upper incisors or the mucosa of the palate when the teeth are occluded. Okay, so a complete overbite, on the other hand, is a relationship in which the lower incisors contact the palatal surface of the upper incisors or the palatal tissue when the teeth are in centric occlusion. Now, how do you classify the deep bite? You can either have a skeletal deep bite or you can have a dental deep bite. Now, a skeletal deep bite is basically genetic is the problem, okay? And it is basically caused by the upward and forward rotation of your mandible. Now, here you see, okay, in what ways a deep bite. Now, this is a proper maxilla here. Okay, this is the cranium, of course. So maxilla, and this is the mandible. This is your maxillary dentition, and this is your mandibular dentition. Okay, so you can either have a deep bite because the mandible is rotated anti-clockwise or upwards. Okay, which leads to contact of your anterior teeth and your disocclusion or open bite in the posterior teeth. Now, sometimes the problem may be because of the mandible, okay, which the mandible grows downwards, okay, yes, which leads and the maxilla a little bit of upwards. So, what happens is there is a contact in your maxillary or the anterior dentition and disocclusion in your posterior dentition. Okay, so there are so many things that can go wrong. Okay, you need to identify which dentition is at problem and how do you treat them. Now, features. Basically, a patient with a deep bite exhibits a horizontal growth pattern. Yes, an anterior facial height is reduced, there is a reduced freeway space, and most of the cephalometric measurements, such as your mandibular plane, Frankfurt horizontal plane, and the ascent plane, are parallel to each other. Dental deep bite. Okay, so dental deep bite is characterized by the absence of any skeletal complicating features that are seen in the skeletal deep bite. It can be due to either supra-eruption on incisors or the infraocclusion of the molars. Now, a deep bite due to over-eruption of your anteriors. Okay, usually it is seen in class 2 malocclusions. Presence of increased overjet allows the lower incisors to over-erupt until they meet the palatal mucosa. Excessive curve of Spee and interocclusal clearance is usually normal. Deep bite due to infraocclusion of the molars. Now here I would like to apologize because I'm not able to take the cast and visually show you on where the problem is and how it will look like. If it is because of supraeruption, how it looks like, infraocclusion, how it looks like. But I just want you to get an overall idea so that when the class resumes, okay, we can have a detailed explanation, right, on how this works. So deep bite due to infraocclusion of molars is because basically the presence of lateral tongue posture or lateral tongue thrust may prevent the molars from erupting to their normal occlusion level, right? It basically occurs due to premature loss of teeth and partially erupted molars and large interocclusal distance between your maxillary and mandibular dentition. Now, how do you diagnose this patient? Obviously, from clinical examination, you can see that whether the patient is having a deep bite, study models, and lateral ceph. Now, proper diagnosis should be done to differentiate between skeletal and dental deep bite, right? Lateral cephalogram helps in diagnosing a skeletal deep bite. Reduced mandibular angle you can see, and reduced lower facial height is what you see in your ceph. Now, what are the factors that you need to consider in treating a deep bite, right? It can be corrected by intrusion of your anterior teeth, yeah, or by extrusion of your posterior teeth. Now, I want you all to sit and understand what I mean by intrusion of your anterior and extrusion of your posterior. So you can take a minute and recall. Okay, moving on. The factors deciding to intrude your, if you want to intrude or extrude your anteriors or posteriors, okay, you must understand or take into consideration the lip relationship, okay, the vertical face height, and your interocclusal space. Now, treatment of deep bite can be divided into removable and fixed appliance. In removable appliance, a bite plane is the one that we most commonly give in treating the deep bite. Basically, it is a modified Hollis appliance, okay, with a flat ledge of acrylic. Let me show you a picture. Okay. Yes, so it is a modified Hollis appliance, okay, where you have an acrylic sheet or a plate here, okay, a plane. It is called as a bite plane, okay, and this is called as the molar band, okay. So this is a fixed one, but you can also have a removable bite plane, right? Myofunctional appliances are also used, such as the activator, bionator, and twin block. Okay, now there are few things. Now it is going much more detail into the mechanics and the treatment. You don't have to know in detail, but just know the few bends or the types or few names which comes under the treatment of the bite under fixed orthodontics, right? So there are something called as anchorage bends that we give, okay? Something called as a reverse curve of Spee. Now all of you know normal arch wire is usually straight, right? That means it is parabolic in structure. Now this is called as reverse curve. You see the curve there, right? So what happens? I want you all to imagine how this will work. Yes, so this part will go inside your buccal tube, okay, and when you try pushing this part, yes, when you try pushing, After you have pushed everything back, you see that the anterior segment goes on your gingiva. It is not straight, so it doesn't engage into your bracket. It goes on the gingiva, okay, near your sulcus. You need to push and engage the wire into the bracket. Oh, this is made up of niti, so you know that the niti has the, yeah, so you, sorry about that, so you know that the niti has shape memory. Yes, so what it does is it tries to spring back to its normal position, so in that way, okay, a deep bite is corrected. Now, use of utility arches, right? So there is something called as utility arches, yes, that we give in correction of your deep bite. Again, just know the names, okay? You don't need to know the mechanics, right? So they are activated by giving a V bends, okay? As you can see here, V bends in the buccal segment of the wire so as to produce the intrusive force in your. Now I want you all to see a video on how this works, right? This is an open bite which was already seen, okay. Okay, so you see the curve of P here, okay, just check. This is a mini implant, okay, and an elastic which can be used, okay, to pull down your mandibular anteriors, because you saw in the curve of P the mandibular teeth is the problem. Now if you see the maxillary teeth is the problem here, you see the curve of P here, okay, so the anteriors are going down, you want to include the anteriors over here, okay, so you can give a midline implant there, okay, you put the bracket, put the elastics, okay, and try to pull this up, right? Okay, so that is how you correct a deep bite. Thank you. If any doubts, please post your comments, and of course there will be an discussion or a assignment on this, so please look for updates in your e-portal and check your Google Classroom, right? Thank you everybody. Stay home, stay safe.